Hello, everyone, and welcome. Thank you for joining us today for this webinar, which is the second in a new series where we are discussing about technology innovations in healthcare. Today's topic is Shift to Value, a primer on value-based care. My name is Shibu Basheer. I'm the CTO at Cabot Solutions, and I'll be your host today. Apologies of the late start. We actually started the meeting and we were notified it's not live, so hence the delay. Thanks, Tanya, for letting us know. Before we start, a few housekeeping points. We'll be taking question and answers towards the end of the webinar. You can post your questions in the chat area, and we'll be recording this webinar, and you will get a link in your email later this week. I'm honored to introduce you to our speaker today, John Porawski, CTO, Chief Technology Officer at Gray Matter Analytics. John brings deep expertise in US healthcare analytics and value-based care, and he'll be sharing his valuable insights on how organizations can adapt to this evolving and changing landscape. Welcome, John. Before we dive in, could you share us a little bit about yourself and about the work you do at Gray Matter Analytics?
Sure. Thanks, Shibu. Good morning, good evening to all the attendees. My name is John Porawski, and I'm the Chief Technology Officer at Gray Matter Analytics. I've been with the company for 3 years, and I've been working in software development for about 25 plus years. Over the last 14 years, I've been in technology leadership positions such as CTO, primarily focused on healthcare data analytics in the space of value-based contracting. I oversee the product development engineering team, data operations, security compliance, and IT. So thanks for giving me the opportunity today to speak today about this important topic, Shibu.
Thanks, John. Could you start by giving us a high-level overview about value-based care and why it's important in today's US healthcare landscape?
Sure. Value-based care or contracting has actually been around for quite a long time. It's an alternate delivery model, reimbursement model to fee-for-service or volume-based, which has traditionally been the mechanism by which providers were incentivized and paid. And value-based care is a healthcare delivery model that focuses on improving patient outcomes, the quality of care while controlling costs. So instead of payers paying providers based on the services they're rendering or volume-based reimbursement model, value-based contracting ties payments to the quality and efficiency of care provided to those patients and outcomes. And really, there's probably 5 to 6 key elements of EBC. First and foremost, it's patient-centered. So care is designed around the patient's needs and preferences, aiming to improve their overall health and experience. Second, it's quality over quantity. They're being measured and reimbursed and incentivized based on the quality of care that's delivered, not the quantity. It's focused on reducing and being cost efficient. So unnecessary or higher cost services are really looked at and highlighted. Obviously without reducing the quality of care being given to the patient. The fourth kind of pillar or key element is care coordination. So really enhancing the coordination amongst all the healthcare providers. So if you're going to a primary care doctor and then going to see a specialist, they want that to be synergistic. And then the final element is really focusing on health equity so that all patients are included and no one's marginalized in this effort. So really, again, the highlights that they're looking for is leading to better health outcomes, lower cost, and increased access to care.
Okay. So in terms of the patients or healthcare providers, what differences would they see with the value-based care when they go into a hospital that uses value-based care compared to the traditional fee-for-service model?
I think it could be many things. For example, when you turn 45 and you're really as part of preventive care for colorectal cancers, there's a screening that's done, being sent to not to the hospital, but to a lower cost facility outside that you'll just get the same quality of care there. It could be looking at social determinants of health and how that might be impacting. For example, you might have a a person who's in Medicaid who has access to transportation barriers. So providing services so that you can get those folks into the clinic. You'd rather have them come into that setting than get really sick and go to the ED. So that all synergistically helps to get access, have equity, but also lower cost. And the patient ultimately is healthier.
I've visited hospitals both in Canada and US. And in some cases, I've seen the doctors take a lot of time, spend time with you, ask the right questions. They're not in a rush, but in other cases, they're in a rush to get you up, 10 minutes, 15 minutes. So is that could be the difference? In one case, they're using value-based care, and the other could be, quantity versus quality.
It could. A lot of that in the US here, where patients are scheduled in 10-minute segments. Really, the doctors are overwhelmed with the things they have to do in a very short period of time. So giving them the ability to not really frame their whole business in their schedule around just fitting as many patients onto their schedule as possible. And giving them the latitude to really focus on the quality and spend more time with patients that are sicker and really need that time is going to reframe how they run their business. And our analysts are helping to inform them on those decisions.
Okay. And despite the clear benefits of value-based care, many organizations are struggling to implement it. What are the main barriers of adoption that you see in the industry?
Yeah, I think there's a couple. One is having actionable insights to data. And so a lot of these organizations either are data poor or they're data rich, but information poor. And so what I mean by that is that, payers often have access to claims data. Obviously, they're paying for those services rendered based on a claim being submitted from a provider. But they have the data, but there's no actionable insights. They have to drill down and spend a lot of time slicing and dicing things, but really very little insights are generated from that exercise. And they spend a lot of time and a lot of manpower doing it. And it's often done through Excel and other, low brow methods. So having, a platform that can surface those insights is key. And then in some of the cases, the providers, they're getting these insights or even the data from the providers, but they're only getting it once a quarter. And given claims lag and other elements, it's not actionable at that time. It's old and it's stale. So really having actionable information is really important to be successful in these contracts. So there's an element of having access to it, the timeliness, working in Excel, but not or PowerPoint, but not having access to actionable details like member lists, it being old, 60 to 90 days old. There's also historically been a trust issue between payers and providers in these contracts. Some of that has to do with, costs and services being lowered or information being shared in a timely fashion or the trust of the data that is they're being judged on. It's the collaboration or lack of the ability to be collaborative and be a partner between the payer and provider. And then there's just a general risk aversion that providers have primarily to get into these contracts because they don't know what they don't know. And they don't have information to be successful.
Okay. You mentioned data rich, but information poor. Can you elaborate? Maybe if you have some examples on some actionable insights that you might get from data.
Yeah, I would say that often payers have Power BI reports or Excel reports that have a lot of information, but they're not highlighting insights to the consumer of the information. If you've got a Power BI report where you're looking for a trend or a change in something, so to highlight that you have to sift through large amounts of data to find that insight if you even find it. And so rather really what we're focused on, and we think it's important, is to provide actionable insights to folks. That here's something that you could do that would move the needle in X, Y, or Z way.
Okay. And you mentioned a trust issue between payers and providers. What is that all about?
Yeah, as I was talking about earlier, I think it's multifaceted. Some of it's rooted in, so for example, if you look at a quality measure in one of these contracts, diabetics, poor control for their A1C levels, that's kind of a measurement of how sick they are with diabetes. They might not trust the number or the rate that's being calculated for that measure. Let's say that the payer is calculating a score of, let's say 50%, but the provider thinks they're performing at 80%. So they're taking care of that population really well, but the payer doesn't believe that. And then there's dollars tied to their performance. So if they're not at 70%, for example, they're not going to get incentive or they'll be at risk of losing money. That becomes a sticking point. And so that could be attributed to a lot of different things. Maybe the payers don't have access to lab data and are incorporating that into their reports. That could be one reason why. But ultimately, there's a mistrust because oftentimes these measures and cost are a reflection of how well they're taking care of the patients. And providers are often a proud group, and they think they're taking care of them really well.
Yeah. Can you explain a bit about the actual technology that gray matter provides and how it helps organizations in implementing value-based care?
Sure. Let me share my screen. Got some visuals here to guide the conversation. Can everyone see my screen?
I can,
Shibu?
but yeah, I can see.
Okay, great. Just make this a little bit better. So yes, Cortex is our value-based contracting product that we have here at Gray Matter Analytics, and there are really three key modules in the platform that are providing value to our customers, which are either payers or providers, or in some cases, payers that are provisioning access to providers to manage these contracts and transition from, as I said earlier, fee for service to value-based contracting. So at the center of this is our contract insights module. And this is where you can see your portfolio of contracts that the payers and providers are contracted in. And this is helping them provide insights and actionable information about cost savings, quality of care, and cost and utilization. We then have our performance insights module, which is more of a holistic set of actionable insights and data and insights around cost, quality, and provider performance management. And then the third and final module is our population insights, which is the ability to create cohorts and patient and member lists, for example, for care coordination. So the Cortex is software as a service. Really, some of the key value propositions are near real-time data and insights. It's a single source of truth where you can take in administrative claims data and clinical data and have a single source of truth for both the payer and providers. They're looking at the same data, the same insights, the same contracts. The data is available all in one place and can be accessed by multiple stakeholders, whether they're executives like a CFO, chief medical officer, even practices and providers. The system allows the ingestion and to make actionable insights from disparate data sources. So as I mentioned before, administrative claims data, clinical data sourced out of the EMRs, such as labs, immunizations, getting data from HIEs or health information exchanges to really provide a robust and comprehensive platform to provide insights on the quality of care and cost. And this is all hosted in the cloud. So we're able to take advantage of the elasticity and innovation that's being done in the cloud, whether it be AI, Gen AI, and so on and so forth.
Pulling in data from multiple sources. You mentioned various sources. What are some of the sources? Like it could be the EMR, EHR systems. What other systems are you pulling data from?
Yeah, I'd say there's three core ones, and then there's some supplemental ones. So it's administrative claims data from payers.
Okay.
So things like claim lines, membership, provider rosters. It could be contract information, contract panels, data, as you mentioned, from EHRs or EMRs. So that's clinical supplemental data. It could be labs It could be depression screenings in the form of a PHQ-9 survey. It could be immunizations that are being given to kids 2 years old. It could be information sourced from health information exchanges across maybe a state or a network within a state.
Okay.
Again, those could be immunization registries. They could be ADT messages, which are basically discharges from the hospital. So there's a wealth of disparate information that could be ingested in the platform to help power these insights in the platform.
Cool. And you mentioned real time. So how old could that insights be? Is it 1 day, 2 day, a week? I know
It
traditionally it could have taken a months or a quarter to get the data, but yeah.
Correct. That was one of the challenges that I was mentioning earlier about when payers and providers are partnering in these contracts. They're often quarterly, so we can adjust the data as quickly or as frequently as a customer can get it to us. Oftentimes with claims data, that's monthly. Sometimes clinical data can be sourced, daily or weekly. And then obviously things like ADT and HIE integrations, it's more timely, so that could be more in real time. So someone actually gets discharged. There's certain messages in technology like HL7 that's powering that, and that's more real-time analytics.
Okay. Do you have any, use case or an example where core tech has been successfully implemented in this value-based strategy?
Yes, we recently did a pilot last January with the Oklahoma Healthcare Authority, and they recently signed up to be in a subscription with us. You can see the press release out in the publicly available. But they recently, in the state of Oklahoma, started contracts with to take care of the Medicaid population with 3 MCOs, managed care organizations. So we're helping to help them be successful in those arrangements and take better care and manage that Medicaid population better. So that's one example.
Okay. And for organizations who are, starting their, value-based care journey, what are the first steps that they should consider taking, to be able to, transition smoothly into VBC? What is your advice to them?
Yeah, I think having a tool like Cortex is important so that they're positioned and they can plan and prepare themselves to get into these contracts, which I mentioned earlier can be risky. I mean, there's the potential to lose money. Often you'll get into a less risky contract at the beginning, and as you succeed in those contracts, you'll move into more risk, which with more risk comes more reward in terms of how much money and incentives you're getting. But it's really important to have the technology and the insights that you can act on. And we feel that Cortex is a solution that helps them do that and transition from this old alternate model of fee-for-service into value-based care and then to be successful.
Is it possible to move in gradually rather than, like switching over?
Yes, absolutely it is. Oftentimes these contracts, like I said, when you first get into them, they're less risky. Maybe you're getting incentivized based on just providing certain services like doing immunizations, which can be one type, and then fully capitated contract where you're taking full risk, and you're getting paid as maybe a certain amount per patient. And then obviously if the cost is lower, you reap the benefits of that. So there's various flavors of contracts that you can get into, and they really span the spectrum of low to high risk, and with the higher risk comes the higher reward.
And what are the future technology innovation do you think that'll have the biggest impact on value-based care? Examples of, I mean, AI is talked about a lot in the past few years. What are some of those kind of innovations coming in?
Yes, I think AI is definitely a big one. More recently, as I think everyone's heard, with the news recently, DeepSeek and Gen AI, really leveraging those technologies, we see a lot of our customers and even some of the technology we're using. As an example, I was at the Microsoft AI tour last week here in New York at the Javits Center, and there was a lot of talk about using Gen AI, ambient technologies to really help providers and payers, automate stuff, provide actionable insights to them. So I think leveraging those technologies, given a real problem in the space is critical.
And one of the concerns that I hear when going out and proposing solutions like these is you're streaming data to the cloud, compliance, HIPAA. What do you say to customers to and users of the systems to ensure that they're taken care of?
Well, I think security and compliance has always been a top of mind of all of our customers. They are very interested in, and often we go through rigorous security assessments with them, and are earning certain security accreditations to prove how compliant we are with HIPAA and high trust and things of that nature. But yes, I think the newer technologies, there's an enhanced concern about not just security, but leveraging things like AI and having ethical bias be involved in that. And so there's more complexity to it, and therefore more concerns about how the data is being used, what decisions are being decided based on, what decisions can be made based on that, biases, in addition to more of the traditional security concerns about PHI, protected health information, where that data is being stored, and avoiding a lot of the things you see in the news these days about data breaches, whether they're healthcare related or otherwise.
Okay. Thank you. That's all the questions I had. It's been, very insightful. I'm going to open the floor to Q&A, and if we have several folks viewing us live, if you have any questions, please do post it in the chat area. While we wait for that to come in, I was chatting earlier with a colleague, and she was asking, like, can you give us some examples of KPIs and insights, that organizations can derive from this technology uh, to help them in the value-based care?
Yeah, I think one of the more exciting ones is we have some what we're currently working on is cost savings opportunities. So folks that have gone to the ED, where can visits be prevented? And what would be the cost in terms of savings of that? Well, we recently are going to be rolling out, also looking at outpatient. And so the example that I mentioned earlier, where a colonoscopy is done in a hospital setting, is more expensive. So you can reduce costs by referring them to other sites of service.
Okay. Here's another question I got. How do you implement VBC at scale? Like, you're pulling in data from a lot of systems, and hospitals could have, hundreds, if not thousands of clinics. So you're handling lots of data. How do you handle that in scale?
That's a good question. I mean, I think you start off small with a couple contracts. I'm not sure if the question's from a customer's perspective or implementing the technology or implementing a product like Cortex. But I'd say generally, like most things, start off small, simple, and like I said, low risk at the beginning in terms of which contract you're getting into. And then as you get more comfortable and you're succeeding, increasing the scope or increasing the risk of those contracts would be my general answer.
All right. I'm just still waiting for questions to come in, but let me see. There's a question, how can real-time analytics help in preventative care and reducing hospital readmissions?
Yes, well, I think it's highlighting, as I was mentioning, those cost savings in terms of preventable ED visits. What was the first part of that question around preventative care? Yeah, CMS, HEDIS, NCQA are three different bodies, or they're actually two different bodies that put guidelines together around preventable care. So colorectal cancer screening, cervical cancer, breast cancer, some of the examples of that. So there's specifications and guidelines that are followed in terms of when those things should happen and measuring the providers and the patients in terms of when they become compliant with those. So for example, if you're over 45, you're supposed to be screened for colorectal cancer. Obviously looking at people's ages and then determining if they've had that screening done or not would then be able to you'd be able to ascertain what percentage of folks were compliant in that particular quality measure. So to answer the question, it's primarily done through quality measures.
Okay. I do have a question here from Ursula Burton. Can you leverage the data from HIE on your platform? I think you had mentioned
Absolutely.
that. Yeah.
Yes, often things that are going into HIEs, it could be immunization registries. Those can be used in quality measures. So if you're a child 2 years or younger, you're supposed to have a certain series of immunizations done. So we can use that data, which is often not necessarily billed on a claim to supplement the measurement of that particular quality measure that may be in a contract. It could be ADT messages, so being discharged from the hospital. You know, oftentimes when you're discharged, you're supposed to be following up with your primary care doctor or a specialist about something. That's a great example where we can use that data. Sometimes SDOH, social determinants of health. When you go in to have a visit, you're supposed to be screened for social determinants of health. So a good example is do you have a transportation barrier? Did you have a trouble getting to the office today? Do you have food insecurities? Maybe you're on SNAP and you're getting food assistance from the government. Maybe you only have a certain level of education. So each patient is surveyed on that. And when there's a disparity identified, a certain intervention is supposed to be done. So using that data, can be sourced from the HIE, is important in just discovering disparities.
Okay. I have another follow-up question on emerging trends, and we have a lot of startups and companies who follow us in the webinar. Um, what are some other emerging trends in technology that can help in value-based care? I know we are talked a lot about insights and analytics. Are there other things that you're seeing and that's evolving in the market?
I think one interesting thing we're doing today is predicting the compliance of a patient to be in one of these measures, their compliance or not, and using different features or variables to make that decision. So it could be an SDOH variable. It could be if they have a PCP assigned or not. It could be what medications they're taking. And so being able to predict the compliance in a measure, which then informs financial outcomes that might be able to be obtained or not obtained is important, and one new feature that we're going to have in the product soon. So
Okay.
absolutely, AI, Gen AI are two of the probably more promising emerging technologies.
Okay. Cool. I think that's just enough time for our questions. John, I'd like to thank you again for presenting here today. It was very insightful, and we will be sending out.